The context of this organization will be the definition of prevalence of CKD and hypertension, CKD cardiovascular, ABPM patterns, the relationship of patterns of CKD and blood pressure with target organ damage, something to say about the current guidelines and possible ABPM therapeutic intervention. So the definitions of chronic kidney disease must be defined by the cause, like diabetes, hypertension, obesity, or glomerular disease. Stages of estimated glomerular. So the prevalence. Ladies and gentlemen, I would like to thank the conference. Dear ladies and gentlemen, I would like to thank for this opportunity to present this presentation about ABPM in chronic kidney disease. The context of this presentation will be the definition and prevalence of chronic kidney disease, CKD and hypertension, CKD and cardiovascular disease, ABPM patterns in CKD, the relationship of patterns of circadian and blood pressure with target organ damage, something to say about the current guidelines and possible ABPM therapeutic interventions. So the definitions of chronic kidney disease must be defined by the cause, which can be diabetes, hypertension, obesity, or glomerular disease, varies. Stages of estimated glomerular filtration and/or albuminuria in these stages present for 3 or more months. So the prevalence of death for chronic kidney disease is rising according to global, regional, and national burden of chronic diseases from 1990s to these days. The prevalence of CKD is almost doubled. In Croatia, for instance, the prevalence of CKD today is about 13% alone. The cause for this is the higher prevalence of type 2 diabetes as well as hypertension as a major contributors to chronic kidney disease prevalence. Believe it or not, impaired kidney function is a risk factor and takes more daily days of life globally than cardiovascular diseases. But in Central Europe, still prevalence of cardiovascular diseases is more than prevalence of chronic disease. This is an old slide, but from a good study with more than 1 million participants, where it's clear that the death from any cause is rising linearly and steeply with fall of GFR. The age-standardized rates of cardiovascular events as well as hospitalizations is linearly connected to chronic kidney disease. So we can say that the risk of cardiovascular death in advanced stages of chronic kidney disease is more than 200%. That is, we like to say that people with a GFR in stages 4 and 5 are more likely to die from cardiovascular events than to be lived and to live to dialysis or transplantation. The association of chronic kidney disease in an estimated GFR with cardiovascular mortality is not linear, it's actually curvilinear. So we can say that for both people with diabetes and without diabetes, the risk of cardiovascular death is higher even in those with glomerular hyperfiltration. Unlike albuminuria, well, the connection is obviously so the prevalence of hypertension is very high in chronic kidney disease. It is reversely related to estimated GFR, and we can say that both hypertension is cause and consequence of chronic disease. The problem of hypertension in chronic kidney disease is misclassification of hypertension status in CKD patients. Like in this study of Afro-Americans with ABPM, nocturnal hypertension was a significant contributor for misdiagnosis of hypertension. We can say that 70% of those CKD patients have mild hypertension. In other words, 1 of 3 CKD patients is misclassified when using only office blood pressure measurement. And we can say that 30 to 40% of patients are clearly missed, and we're talking about high-risk cardiovascular patients. But there's another problem, and that is different prevalence of various patterns of blood pressure phenotypes across literature. For instance, white-coat hypertension in CKD patients is found from 2% to almost 30%. Mass hypertension from 30% to 70%. Same is like with nighttime mass uncontrolled hypertension. And the various causes among literature can be found, like casual versus standard office blood pressure record using office versus 24-hour or daytime ABPM measurement as was defined in our guidelines. Using different thresholds for CKD patients now with different European, American, Canadian, and so on definitions of blood pressure thresholds for CKD patients. And for when it comes to nighttime mass hypertension, usually mass hypertension during night is double mass by using different definitions of uncontrolled mass hypertension, that is using 24-hour versus daytime or nighttime uncontrolled hypertension. What I'm trying to say here on this patient case, like this patient with CKD C3B-A3 stage, he's a type 1 diabetes, and when you look at his daytime blood pressure measurements, he's obviously well controlled, but his nighttime hypertension is mass uncontrolled nighttime hypertension. He also has obviously reverse different pattern, and heart rate is also this. This is a graphical example of the same ABPM finding. So according to his diary, he did some household maintenance, and during night he slept well, and this is obviously mass uncontrolled hypertension, which would be missed if we only look at daytime or overall 24-hour measurement. The IDEA study tried to combine different cohorts of CKD patients where ABPM was used. This is the Afro-American previously mentioned study. This is the American study also, but only with patients with mild to moderate CKD, referred to nephrology specialist office. This is the Italian ABPM registry. This is the Spanish ABPM registry done by primary care physicians, and this is the Japanese study. It is clear different between the rates of control among those referred to nephrologists with mild to moderate CKD, unlike those taking care of primary physicians, and randomly selected from their registry. And there is a clear difference between sustained hypertension and rates of control between American and European cohorts. The authors of the IDEA study are stating the differences: lifestyle, diet, genetics, healthcare system, and so on. But I think the differences between the healthcare system in USA and Europe is quite different, and the accessibility to ABPM is very different in the States and in European Union. So the characteristics of ABPM patterns in CKD are altered circadian blood pressure rhythm, blunted amplitude of circadian variation, increased rate of non-dippers, which is even more increasing as CKD stages progress. And also the morning hypertension in CKD is different than morning hypertension usually seen in other patients with hypertension. It is usually sustained, and there is no surge type of hypertension during morning in CKD patients. So the hallmarks of hypertension in CKD is mild hypertension, nocturnal hypertension, and very high cardiovascular risk, target organ damage, and increased mortality among CKD This is the cohort from her meta studies, but nevertheless, we cannot ignore the fair amount of CKD patients from various CKD stages, and there is a clear difference between systolic blood pressure readings among those with CKD and those without CKD patients, as well as the nice example of undeepening during the night among CKD patients. So in this meta cohort, the 90% of hypertensive CKD patients had uncontrolled nocturnal hypertension. It is also seen that as the CKD progresses, systolic and systolic blood pressure fall, that is the different status in night is decreasing, as well as the increasing of rises in advanced CKD. And the progression of systolic blood pressure and downfall of diastolic blood pressure fatal or non-fatal cardiovascular events and renal death with ABPM and office blood pressure, and it is clear that systolic daytime uncontrolled hypertension is a good predictor of fatal and non-fatal cardiovascular and renal deaths, as well as even more nighttime systolic blood pressure. And this was independent for other cardiovascular risk factors, but when it comes to blood pressure measurements, it doesn't predict any of the mentioned hardcore outcomes. Also, the non-dipping and reverse dipping in CKD patients is also able to predict fatal and non-fatal cardiovascular and renal events. So we come to a problem where the lack of prognostic interest of office blood pressure significantly demands our guidelines recommendation, where the office blood pressure measurement is still the hallmark of hypertension diagnosis. And in CKD patients, this is obviously not true. This is a clear U-shaped curve of systolic daytime blood pressure and the nighttime blood pressure in CKD patients, where if we try to lower blood pressure according only to office blood pressure measurements in high-risk renal, elderly flare patients and those with vital hypertension, we risk severe adverse events. And this is why it is even more surprising that and high cardiovascular risk patients can be really dangerous. It is never going to debate whether different status if there's any load of cardiovascular risk beyond blood pressure control. Well, in this recent study, again from Italy, it is clear that not different status with control hypertension in ABPM carries cumulative incidence of cardiovascular as well as renal endpoints. So we can say that the loss of different patterns carries cardiovascular risk similar to that of uncontrolled hypertension in ABPM, regardless of blood pressure being on goal, and it is independent of other cardiovascular and other risks. In this German study, where they try to assess target organ damage, which is usually done by assessing left ventricular mass and pulmonary velocity, in mild to moderate CKD patients, the white-coat hypertension was associated with target organ damage, and mass uncontrolled hypertension and sustained hypertension have similar symptoms. In this Greek study, coming from the United States, with the low prevalence of advanced CKD and most patients being well controlled, because they use different definitions of control and mass hypertension, but never again in Greek studies also in the high prevalence of sustained marked hypertension in advanced stages of chronic kidney disease, and this is even more pronounced with albuminuria. So the higher albuminuria, the higher proportion of sustained and marked hypertension it is in this cohort. As I said, quick study has some quite differences between those from European cohorts. They had a high proportion of controlled blood pressure, which is unusual for CKD patients, and very little of those with sustained and masked hypertension. But nevertheless, in quick study, nighttime masked uncontrolled hypertension was more pronounced in people with left ventricular hypertrophy and with those with increased cardiac femoral pulse rate velocity. This is associated with lower GFR, proteinuria, with diabetes, and with black race. In this study, white uncontrolled hypertension was not associated with target organ damage. As I mentioned, this study from my nephrologist point of view had some methodological issues. Unlike quick study, again coming from Italy ABPM registry, the risk of end-stage renal disease and death is similar with those with mild and sustained hypertension, as well as, of course, mortality. And in quick study, again, only composite cardiovascular outcomes were associated with mild and sustained hypertension, while all-cause mortality in quick study is not associated with mass or sustained hypertension, which is so the 15 years have passed since and experts try to address the problem and the necessity for using ABPM in chronic kidney. But still, some guidance is currently on call, like American Heart Association guidelines are trying to push lower thresholds in CKD patients with 120 or 70. CKD, though, is highly criticized among the nephrology unit because going lower than 120 office blood pressure it can be dangerous. Whereas a European guidance is recently published clearly say that lower than 140 over 90 office blood pressure measurement with CKD is good enough. We can go lower below 130 in those younger, those with hypertonuria and high cardiovascular risk, and they say that clearly lower than 120 or 70 is not recommended. Again, there is a sentence in our guidelines that the ABPM is preferred over home blood pressure measurements due to high prevalence of nighttime hypertension, non-typic status, and mass uncontrolled hypertension. A little is to say about pathophysiology of disruptive CKD written in CKD patients. So, activation of renin-angiotensin system in early stages of CKD can be overcome with appropriate dose and early implementation of valve blockade. Sympathetic nervous activation also prevalent from very early stages of CKD must be treated with temporal pharmacologic drugs, and they should not be dismissed in CKD. They can be applied with advanced stages of CKD. Increased sodium retention and low adherence to low salt diet can be overcome with appropriate dose and combination of different products. So to conclude, the elevated nighttime blood pressure component of cardiovascular and renal risk, ABPM is far better tool for predicting renal and cardiovascular outcomes rather than office blood pressure. ABPM is better tool for predicting CKD progression, end stage, and death. And it is additive and a prognostic value for CKD patients. In our center, ABPM is mandatory in every CKD patient. And as we think it should be. There are some unknowns. In this case, the interventions that try to reduce left ventricular mass in trials did not have a parallel decrease in mortality among CKD patients. It is unknown whether or not the treatment with ABPM patterns, nighttime blood pressure and so on, will have some outcomes on hardcore or other soft outcomes like heart velocity. And there are no randomized trials on purely ABPM guided strategies in treatment, and even master study and other trials usually exclude CKD patients, so we can say there will be no randomized trials on purely ABPM guided. I would like to thank you once again for your attention and hope to see you in Zagreb this October on 9th pre-hypertension meeting. Thank you.